Hello, everyone, and welcome to today's Adult CLL chapter event brought to you by the HealthTree Community for CLL program. My name is Katie Braswell, and I'm the Director of Education at HealthTree. I'm so grateful to have each of you here today for our very first CLL meeting and for your support in building this CLL community together. I'd like to let you know that today's session will be recorded, and the recording and any resources we discuss today will be sent out via email to all registrants within 48 hours after the event has concluded. The recording will also be placed on HealthTree's YouTube channel and our website in an article format as well. We'll start with a brief Zoom meeting tutorial for those of you who are new to using Zoom. We would love for you all to turn on and keep your cameras on if you feel comfortable. Doing so helps us to create a stronger sense of community. You can see at the bottom of the slide how to turn on your camera. You should see the microphone and camera buttons. You can click the video icon that says Start Video in order to turn your camera on. With that being said, if you're not comfortable being recorded, you're not required to keep your camera on. Your microphone should currently be off and will be kept off by our team throughout the presentation. During the group discussion at the end, you're welcome to unmute yourself once you're called upon if you would like to make a comment or ask a question. If you have any questions or comments for us or for our speaker throughout her presentation, you can click the chat icon and type them there in the chat box. If you're using a mobile device or a tablet, click the three-dot icon that says More and then Chat in order to access that chat box. And lastly, if you would prefer to verbally ask a question or make a comment directly to our speaker during the discussion time at the end, we encourage you to do so. If you're using a laptop or desktop, click Reactions near the bottom of your screen and then click Raise Hand. If you're using a mobile device or tablet, you can click the three horizontal dots that say More and then click the Raise Hand button. And now let's get started with today's event. First, I'd like to thank our sponsors who make events like this possible, who are AbbVie and Genentech. The topic of our event today is infection prevention for CLL patients. Here's the agenda for today. First, I'll introduce our speaker, Dr. Meghan Thompson, and she'll spend the next 30 minutes or so giving us her presentation. After the presentation, we will open it up for your questions and comments. So let me take a second to introduce our speaker, Dr. Meghan Thompson. Dr. Thompson is a medical oncologist at Memorial Sloan Kettering Cancer Center in New York, who specializes in the care of patients with chronic lymphocytic leukemia, Richter transformation, lymphoproliferative disorders, and other leukemias. Dr. Thompson partners with patients and their families to formulate a personalized care plan based on their cancer biology, medical history, and individual goals. She is passionate about educating patients and their families on their diagnosis and treatment options, as well as learning what is most important to each patient as they begin their care journey with her. Dr. Thompson has worked with us over the past year to create videos for HealthTree University, which is our online CLL curriculum, which you can find on our CLL website. And we are honored for her to spend the afternoon with us discussing the very important topic of infection prevention. So with that, Dr. Thompson, I'll turn it over to you.
Thank you so much for the kind introduction, and I'm really thrilled to be here with this group and give a little bit of background and, most importantly, answer your questions surrounding CLL, and we're going to focus really on the immune consequences of CLL. So I just want to begin this afternoon by providing an overview with CLL and how I kind of approach it when I meet a patient in the clinic, and then we'll kind of delve into more specifics. So CLL, or chronic lymphocytic leukemia, it's the most common leukemia in the United States, and it's a blood cancer. And when I think about the blood system and blood cancers, I tell patients, when we think about this organ of the body, it's really the bone marrow that produces the blood cells. And there's three main types of cells we focus on when we get that CBC or complete blood count report. So one are the white blood cells, and these are cells that are made by the bone marrow, and white blood cells we all have as part of our immune system, and there's different types of white blood cells. And specifically, one type of white blood cells is called lymphocytes. And even within that, we have different types of lymphocytes. One type of lymphocytes are B lymphocytes, and we all have these cells, and they're our antibody producing cells of our immune system. And in patients with CLL, this is the cell that is abnormal. For a reason we still don't fully understand in 2024, patients with CLL have collected in their blood and their bone marrow is producing abnormal B lymphocytes. So there's too many of these cells in the blood. And I think about the B cells or B lymphocytes seen in a CLL patient as each cell has its own unique fingerprint. And so when we diagnose CLL, we look at that fingerprint of the cell, and that's determined by the pattern of proteins that are expressed on the cell. And a lot of your doctors have probably sent a test called peripheral blood flow cytometry, and they're able to diagnose CLL basically based on the cell's fingerprint or pattern of proteins that's expressed on the cell. So in CLL, those lymphocyte cells are abnormal. There was a genetic change that occurs, and too many are being produced and accumulating in the blood, and in some cases in the lymph nodes and other lymphatic tissues. I just want to highlight the two other main cell types on that CBC or complete blood cell count test. There's red blood cells. These are measured by the hemoglobin. And your red blood cells are your oxygen delivering cells to the tissues in your body. And if your hemoglobin, for example, is too low, that's something called anemia or anemic. And that can happen in CLL patients, but not all CLL patients are anemic. The third main type of cell to focus in on that complete blood count are the platelet cells. These are cells made by the bone marrow that are helpful if you cut yourself. They help with the formation of a clot to stop bleeding. And platelets can also be normal or abnormal in patients with CLL. So that's kind of a general overview as we kind of talk about CLL and how it affects the immune system. I really think of it in this way because the CLL cells are abnormal lymphocytes as a cancer of the immune system. It's the most common type of leukemia. It's more common in men than women, although I have many female patients with CLL. And the average age at CLL diagnosis is around age 70, but there's many patients who have CLL even in their 20s, 30s, 40s, 50s, so it can affect patients with younger age as well. There's some other conditions related to CLL that we should mention too as background. There's patients with something called MBL or monoclonal B-cell lymphocytosis. This is a pre-CLL condition. In order to make the diagnosis of CLL, patients have to have a certain number of these abnormal B cells in their blood, 5,000 cells per microliter or more. In patients with less than that, there's a pre-CLL condition called monoclonal B-cell lymphocytosis. Then there's another related diagnosis called SLL or small lymphocytic lymphoma, which is treated and managed very similarly to CLL, but is when these abnormal cells aren't as much in the blood, but they are more in large lymph nodes in the body. So that's more of a lymphoma manifestation of this leukemia. But one of the common uniting factors with all these diagnoses are they are, with MBL precancer and CLL, SLL cancers of the immune system. And so along with that, there are some special considerations in terms of preventative care. Now, it's really important to note as we talk about CLL, SLL, that not all patients with the disease need treatment at the time of diagnosis. And this can have impact also onto the immune system. So approximately a little over a third of patients at the time of diagnosis, approximately a third, I'd say, don't need treatment right at the time of diagnosis, but need treatment at some point during their diagnosis with CLL. Approximately a third of patients never need treatment, and another third of patients need treatment right at the time that they're diagnosed. The most common, though, situation with CLL is that patients are diagnosed incidentally. They get blood work for another reason, and they don't have symptoms upon presentation. And many of those patients might not meet criteria for treatment. Now, we don't treat CLL unless CLL is causing a problem. And we have specific guidelines and criteria for, what that problem is. The reason we don't treat CLL unless it's causing a problem is because there's been studies that have been done over the years, and there's never been shown to be what we call an overall survival benefit or extension of one's life by doing treatment earlier. And earlier interventions do subject the patient, potentially to side effects from the treatment, as well as might have some influence and impact on the biology of the CLL itself. And so we generally wait still in 2024 for patients to meet a criteria where the CLL is causing a problem. Now, sometimes this can also be different for different patients. So some patients need CLL treatment because it's affecting those other blood counts, the hemoglobin or the platelets. Some patients need treatment because lymph nodes grow big or bulky. Some patients need treatment because the spleen is enlarged and is causing symptoms. And in some patients, the CLL can be responsible for symptoms such as fevers, drenching sweats, things like where you're changing your shirt or the bed linens, or fatigue, that we look into other medical causes, other problems that could be causing this, and we don't find any, and that is a reason to treat the CLL. The lymphocyte count itself is tracked over time and is a marker of the disease. But generally, it's not the white blood cell count alone, but the white blood cell count plus one of these symptoms that warrants treatment intervention. So it's very personalized to you, between you and your doctor about monitoring, because you might, your CLL might be more causing the enlarged lymph nodes or the enlarged spleen or more affecting the blood count. So that's why CLL is monitored over time. For patients who don't need treatment right away, many of them, if they don't meet this criteria, enter into a period of what I like to call active observation. And in this active observation, I partner with the patients to see them typically during the first year of diagnosis. It's every 3 months to get a sense of the pace of the disease, check their blood count, do a physical exam for lymph node or spleen. And then the duration between appointments really is based on that disease tempo, how things are progressing over time. And we monitor for development of these symptoms. And patients who need treatment, then I come up a comprehensive history with the patient to really look at their other medical conditions and ways that they can, different options and what might need to be appropriate for them, both standard treatments and then, if available, clinical trials. So those are some things to keep in mind when you talk to your doctor. One of the things, though, that I review for all patients, regardless of whether they need treatment or are in a period of active observation, is thinking about ways that CLL, impacts the patient's health beyond just whether you need treatment or not. So one of the unique things about CLL being a cancer of the immune system is that we do see that patients with CLL have abnormal immune systems compared to healthy individuals who don't have CLL. One of the ways that we see this is an increased risk of infection. And this can actually be in patients even who don't need treatment, who are in active observation just by nature of the disease itself. This is a cancer of those B lymphocytes, as we talked about, but we also know from various research studies that another component of the immune system, T cells, are also abnormal in patients with CLL. So it does affect the immune system in various ways. we do see a higher risk of infection in patients with CLL, including those on and off treatment. So I discuss with patients a couple of ways to try to prevent infections, whether they're on active observation or on treatment. One of the things I discuss with all my patients is the role of vaccines for patients with CLL. For patients with CLL, live vaccines should not be administered. These vaccines have a higher risk of replication in an immunocompromised host. Most of the vaccines that are live are not vaccines that you would get during adulthood. But I do tell my patients this, just to call my office with any recommended vaccine if it's not one of the ones I've gone over and recommended, just to check whether it's safe, say you're traveling to another country or something like that. Non-live vaccines are safe, and there are several that I do recommend for my patients. So, for example, the annual flu vaccine, I do recommend to all my patients. The COVID-19 vaccine series, I do recommend to patients with CLL per the CDC guidelines for immunocompromised patients. Those guidelines are frequently updated as we learn more and more about COVID-19, as well as available new vaccines as they come out. I talk to my patients, so that's something to speak with your doctor about as well. The other vaccines that I do recommend for all patients are the pneumococcal vaccine series, and there's been some recent updates there with what vaccines are available. So it depends a little bit to the patient's situation, what their age is, if they've had prior vaccinations, and what their schedule should be. But I do recommend in general today, there's a vaccine Prevnar. There's Prevnar 15 out there and Prevnar 20. Prevnar 20 is the newest one. And so if patients haven't received any pneumonia vaccines in the past, I do recommend that Prevnar 20. There is another vaccine, Prevnar 15, that is a little bit older, but still one of the frequently used ones. And if patients get Prevnar, haven't had any pneumonia vaccines, Prevnar 20 is not available, then I recommend this Prevnar 15, and then 8 weeks or more later, the Pneumovax 20 vaccine. Now, I should say that these guidelines are frequently updated, and it does depend a little bit on what vaccines you've had in the past, what your age is, but so you should discuss that with your doctor, your specific situation. And the CDC has frequently updated guidelines for immunocompromised patients, which CLL qualifies for. But in general, you should have a pneumonia vaccine series, and that's just two examples of how it could be given. The other vaccine series that is really important for patients with CLL is the Shingrix vaccine series. So this vaccine is a killed virus vaccine, so it's not a live vaccine, so safe for patients with CLL. And it's a two-part vaccine series. Patients get the first shot, and then the second shot can be given 2 to 6 months later. I do recommend this because we do see higher rates of shingles infections in patients with CLL, and shingles infections, although not always, are typically severe, can be severe in patients with compromised immune systems. And then there's a new vaccine that was recently approved by the FDA for patients 60 years and older, the RSV vaccine. This vaccine I am recommending to my patients ages 60 years and older with CLL. We have data from the initial trials of this vaccine in the general population. I have not seen CLL specific data for the RSV vaccine, but it is a safe vaccine based on what we know to administer. And I am recommending this because RSV is a common virus. A lot of times it is seen in younger children, older adults, although it's circulating certainly in respiratory season in the general population. And patients with CLL, given their immune system, are at higher risk for RSV, in fact, more serious, I should say, RSV infections. And so that is a new recent addition to the list of vaccines that I talk through with my patients. I should mention, though, that unfortunately, because of the disease itself, CLL patients do not typically respond to these vaccines and mount antibody responses as well as someone without the CLL condition. So there's been various studies on some of the vaccines, for example, Shingrix vaccinations, the COVID vaccinations, and it has been seen that not all CLL patients form and mount detectable antibody responses to the vaccines. Having said that, these vaccines are safe for patients and there might be immeasurable effects on the immune system. So I think there's little downside, but it is a risk, benefit conversation with your doctor, particularly if you've been on recent therapy. I tend to recommend these vaccines because they're safe, and we can't really predict always who or who will not form an antibody response in patients with CLL. One group of patients that we know doesn't respond as well to vaccines are patients who've received recent rituximab or obinutuzumab therapy. These are commonly used treatments in CLL with various combinations and at stages in the disease, but these are monoclonal antibody infusions that target a protein CD20 on the surface of B cells, your normal B cells as well as CLL cells. So we call this B cell depleting therapy. And these drugs do essentially not just wipe out the CLL, but also your normal B cells. And so we know from prior research that 6 months, less than 6 months, and really in some studies less than a year, if it's been that short period of time since you've received rituximab or obinutuzumab, you're much less likely to form an antibody response because you don't have those B cells. So it's really important to talk with your oncologist about, when did I last receive the rituximab or obinutuzumab, and that can help guide when you should get, for example, the Shingrix vaccination if you were discussing that. I think that also highlights for patients who are in this period of active observation because they aren't on treatments that will add to the disease's, impact on vaccine response. That is a time that I also, kind of review these recommendations and able to work through that list of recommended vaccines to try to get these vaccines, started before patients start treatment if possible. The other thing that comes into play with preventing infections is in patients that have already had a significant history of infections, we can take some other preventative measures. So in particular, we know that patients with CLL tend to have lower immunoglobulin levels. And one of these immunoglobulin, IgG, we can actually measure through a blood test. For patients that have low IgG levels, less than 500 to 600, we can, and they have a history of recurrent sinopulmonary infection. So that's like sinus infection, respiratory infection, pneumonias that have required antibiotics, like 2 or more such infections that are, serious to the point requiring antibiotics over the past year, or serious infections leading to hospitalization, needing IV antibiotics. We can check these immunoglobulin levels, and if they're low, we can consider preventative infusions of something called intravenous immunoglobulin, which is essentially giving the patient an infusion of antibodies from other people, so donate a pooled kind of transfusion almost of other people's antibodies to give what we call passive immunity to patients. So this has been shown in some studies to be a means to prevent infections, and we use this in patients with CLL. So that's certainly something to keep in mind. And your immunoglobulin G levels can be measured through a blood test with your doctor. For patients who don't have a history of recurrent infections, We don't preventatively start IVIG. That's not the current standard based on available data. This is really for patients with history of infection. And then I'm just going to mention that there's a lot we don't know too about the immune system, but there is a lot of ongoing research thinking about how do different treatments that patients are on modulate or change the immune system. And then an area of unmet need that we're thinking about as researchers for patients with CLL is how do are there ways that we can, harness our knowledge and available treatments to lead to any immune restoration. So I think it's always good to keep in mind if there's ongoing clinical trials, ask your doctor, are there any clinical trials that I can participate in? If that's something that interests you as a patient. And sometimes even for patients who are not receiving treatment for their CLL, there can be clinical trials that they can participate in. The other thing I will mention is, your immune system, this being a cancer of the immune system, we do also see an increased risk of what we call secondary malignancies or other cancers in patients with CLL. And one of the most common cancers we see in patients with CLL are skin cancers. And so I do have patients, while this is an infection, I think it's important to mention while we're talking, I do have many patients with skin cancers, and I recommend that all patients with CLL, regardless of their history of skin cancers, establish care with their dermatologist for a skin cancer screening once a year, or for patients who've had history of skin cancers as recommended by their dermatologist. Because a lot of times these skin cancers can be caught during skin checks, hopefully removed before they cause any further problems down the line. And then it's also really important for you to establish care with a primary care doctor, because this is a chronic disease that the hope is for many patients, they're living alongside this disease for decades. And your other medical health is very important. Staying up to date with recommended cancer screenings for colon cancer. So that's a general recommendation for everyone. But as a patient with CLL, I would, make sure you're up to date on the normal recommendation for colonoscopy with your primary care physician. For women, mammography for breast cancer screening. Pap smears for cervical cancer screening, for men, the prostate specific antigen, the PSA blood test for prostate cancer screening, all those usual screenings that are recommended, just making sure you're checking in with your primary care physician and on track for those. And then I would just also say other aspects of health, having that primary care physician to help you, or if you have subspecialists like cardiologists, help manage blood pressure, cholesterol, all of that, just so that all the medical conditions are in check, especially if even if you're, I should say, not on treatment and in this active observation period, making sure those aspects of health are being managed so that we are able to address those other medical problems if we do need to start treatment for the CLL. I think one of the unique things about CLL is that it's, very different for different patients. And so, really, you can see it's yes, about the decision, treatment or no treatment, but it's also about all these preventative things we can do along the way to support patients. So I think, with that, I've been talking for a while. I just like to pause and kind of open it up to anyone who has any questions. I think that we could use the chat feature if that works for you guys, or you can feel free to verbally ask a question. But we'll pause. I've been talking for a while there and see what your questions are.
Thanks, Dr. Thompson. I'll take a peek at the chat. We're a small group, so if you just want to go ahead and come off mute, I don't think we'll have a problem there if anybody wants to verbally ask a question. I do see from Molly here in the chat asking about if there are any vitamins or supplements, minerals even, that you recommend to potentially help the immune system.
Yeah, that's a great question, and definitely something that comes up frequently during the clinic. I would say in general, there is no specific supplement that I recommend for CLL that I've seen convincing evidence to say that this improves outcomes, and that I tell patients to take. I would say in general, like multivitamins are generally safe. Of course, check with your doctor if you're on multiple medications about that. I actually typically don't recommend starting new supplements for the purpose of CLL, especially without consulting about the specific ingredients. The reason being, a lot of the supplements, the over-the-counter minerals or supplements, are not FDA regulated, and so we don't always know the ingredients to them for sure. And especially if you're on treatment for the CLL, there can be interactions there. So I actually tell patients to come to the clinic and bring anything in question, and then we're fortunate in our clinic to actually have a pharmacist, and we kind of go through the various ingredients and we have a conversation what we know and don't know about things. But these, vitamin supplements, minerals definitely have real active ingredients, but it's always a balance because we don't want those causing, an issue for, for example, liver function or anything like that. So in general, there's nothing specific I recommend. And definitely if you're thinking of something, I always think it's best to actually just bring the bottle in with you to the clinic to discuss.
Yeah, and maybe while we're on the topic of supplementation, I know probably the idea of probiotics come up often with the use of antibiotics. Is that something that you're asked about, and what may be your thoughts about probiotic use?
Yeah, I think that's very individual to the patient. Again, it depends a little bit on the ingredient and what we know, and then also on like the patient's blood count. So like, for example, if the patient is neutropenic or has decreased neutrophil or white blood cell, I say avoid the probiotics. Same depending on certain treatments. It's in general, I don't recommend like routine probiotic use. And I'll say this is like an opportunity, I think, for us to really study, hopefully we'll have more research in the future on like specific vitamins, supplements, probiotics, and how they affect CLL, because they definitely have active ingredients. We just don't know one way or the other a lot of times right now.
Great. I see a question from Fred here asking, in the wait and watch category, is it expected that colds will last longer?
Yeah, that's a great question. It's a little bit patient specific, and we're lacking a way to say, like, even for patients who aren't on treatment, we don't have a great measure to say your immune system's at this level or it's at this level. I have seen in my experience that there are patients who've never received any treatment for their CLL, and they do have more serious infections, such as you get a cold and it just doesn't go away. So that's certainly a possibility, and it's still at risk compared to someone without CLL for kind of a more serious respiratory infection. Having said that, there are patients too who have CLL, and they tell me, that that they didn't have a serious cold, just had it 1 or 2 days. So there do seem to be other factors besides treatment or no treatment, even within the no treatment category, that we probably just haven't figured out yet that kind of depend on the response to infections. The other thing that I think is at play here too, and a factor is, we didn't mention this during the presentation, but aging has effects on the immune system too, and the health of your immune system. And we know that, for example, T cells, which are important immune cells, this is not even CLL specific, are less fit in older patients compared to younger patients. And a lot of patients with CLL, have not only the CLL, but it is a more common disease as patients age. And so that's also a factor. And then other medical conditions, things like diabetes, for example, we see a certain increased risk of other infections. And that's a common condition also in patients with CLL. So all those factors can go into play too.
I'm curious myself, in how much of a role in your own practice you play in managing infections with CLL patients. Are you bringing in an infectious disease specialist often, an immunologist? Is it a multidisciplinary approach? How does it work?
Yeah. Well, there's definitely I'm fortunate to work with a lot of team members. So, it's me, I work with several nurse practitioners. I have an office practice nurse. And then I already mentioned the role of the pharmacist. And so in my practice, I'm really fortunate to have all these people, even within our CLL team. Sometimes we do, bring in infectious disease if it's a more serious situation. Sometimes it's, I incorporate all of these. I kind of have a checklist I go through with each patient at the end of the visit, going through, what are you up to date on your vaccines? Have you had any recent infections? Let's screen your immunoglobulin level. And then, of course, if patients do have recurrent infections, sometimes depending on the site of infections, we have infectious disease consultation, or sometimes patients, if it's pneumonias, they see a pulmonologist. So it's a little bit patient specific there, but I think it's a great point that our primary care docs also I'll be in contact with for this, because they've also known the patient for longer than me. And so I just tell my patients, keep me informed of anything, and then, let us where we can help kind of triage you and bring in team members as needed.
Great. I'm seeing a few more things here in the chat. Someone's asking if I know I didn't respond to a vaccine based on titer live measles just before diagnosis. Is it more likely that I won't respond to other vaccines?
That is a great question. I don't know of any data that has really shown that, between vaccines. So I'll start with this. There is some data, for example, with COVID-19 vaccination. We've gotten a lot more data that's more CLL specific, or even if it's not CLL specific, blood cancer or these lymphoid blood cancer specific. And we have seen that in some patients, they didn't respond to the first vaccine, but there were patients who had responses to, for example, subsequent booster vaccines. Not everyone, but there were patients who didn't have an initial response, got booster, and then formed antibodies. For titers of like a measles vaccine, and then comparing that, for example, to a Shingrix vaccine, I don't know of any clinical study that's actually looked at that specific question. I mean, it's possible that there might not be a response, but I think, from my perspective, the take home is there's little downside to these vaccines. And if they're not, the non-live vaccines, ones I went over, like pneumonia and shingles and flu, and they could have other effects that are unmeasured on the immune system. So like when we say titer, we're looking at, antibody response, but there's other ways vaccines can respond, can affect the immune system too. And so I would still recommend to, discuss with your doctor going ahead and getting the standard recommended vaccines.
You mentioned a little bit about the RSV vaccine earlier. Someone's asking if it's been proven in other immunocompromised populations.
Yeah, I haven't seen specific data on like responses in, I mentioned CLL patients. I don't know if CLL specific, the clinical trials were general. And I haven't seen those trials or even like other pooled retrospective studies. So I think that's hopefully something that we will be seeing in the coming year. Hopefully someone will look at that as a research question. It's a great question.
Yeah, that'd be great. Megan's asking if you've seen data that IVIG helps reduce active infections, not just used as a preventative measure.
Yeah, another great question that comes up all the time. The data for CLL is really to be used as a preventative measure, not as generally speaking, as someone is hospitalized with a bacterial pneumonia. In that case, there's other means of treating it, antibiotics, not necessarily IVIG in the active setting to treat it. It's not to say that it's never used. There are perhaps specific circumstances where one would get IVIG infusions, but the idea is while they have an infection, but the idea in general is more for preventative intervention of infection and this idea of like passive immunity and hoping to help future infection prevention.
So Mary's asking a good question. Maybe we can expand on this a little bit. So she's asking, how careful do I need to be during watch and wait in flu season? Should I limit who I'm around? Should I be washing my hands a lot more? I don't want to overdo it or underdo it. So maybe we could talk about some things that we can do day to day to that are probably the most impactful in reducing our risk for infection.
Yeah, I think this is a great point and something that I talk with patients about all the time. And in a way, some patients might have been living with CLL way before the pandemic, and some might have been diagnosed during the pandemic, which I think was a COVID-19 pandemic, which is a particularly, I think, difficult time to be diagnosed with this cancer, thinking about infection and, risk benefit of activities. So in general, I think we've been prepared, the things that we've learned as a society during the COVID pandemic, some of them can really help infection prevention. So one, this is really basic, but like washing your hands really frequently. Two, I think staying away from people who are sick, which is not always possible in our day-to-day life, but I think this came up, for everyone in a way during COVID-19. And just being cognizant, if, so-and-so, I know that they're sick or they've been in contact with someone sick, you have CLL, just trying to avoid that contact as much as possible. And then the CDC guidelines for immunocompromised patients do recommend for COVID-19 prevention, for example, if you're in an indoor crowded space, masking is a tool that should be utilized if you're able to decrease the risk of transmission for respiratory infections. So I think those are some things on the day-to-day, and then really being up to date on the vaccinations as well, getting flu shot. Now, it's not these vaccines for flu, for example, it's not a guarantee that you won't get the flu, but the idea is to prevent a more serious, course of flu, for example, landing in the hospital or something like that.
I think it's tough to really balance the fear of potential infection with the fear of social isolation. How do you do you have any tips that you share with your patients about how they can still live their life and manage that anxiety that probably is, constant about potential infections?
Yeah, I think that's really, really important. And it's definitely a huge balance because we do have to benefit weigh the risk of infection with the risk of isolation, which is really, really real and a huge impact on quality of life. So I tell patients kind of just what we went over, like don't go towards anyone who's sick. And then you kind of have to, the CDC guidance is to wear a mask in indoor crowded places, try to, avoid during peak, as the COVID peak goes up. For instance, right now we're experiencing a little bit higher rates here in New York City. Having that in mind when you think about what activities, and it's really, balancing that risk benefit. But I think it is important to still have some, social contact and be able to do the things you want to do. So working on, maybe some modifications there, but it's definitely a really good point. And I totally acknowledge the challenge, and hopefully, we will work as a field on research to help restore the immune system. I think that's kind of, a goal alongside improving treatments and trials to look at new and novel therapies to treat CLL. This is also something that we need to do more work in, and we're hoping to do.
Yeah. So in a similar topic, Anne Marie is in the watch and wait category. She has young grandchildren and they keep getting colds. And well, I'm not sure probably both. Her grandchildren are getting colds and she's getting colds that last longer than usual. Her IG levels seem to be okay. Is there anything else that she could potentially do to limit getting sick for so long?
Yeah, that's a good question. I would say talk to your doctor about your blood counts and just making sure that depending on the type of infection, there's no like preventative antibiotic or antiviral you should be on. That's one thing we haven't talked about. In general, there's not like pan recommendations that like everyone should take antibiotic or antiviral. But there are specific circumstances where I recommend that. Like, for example, if the patient has this prolonged neutropenia, sometimes we do preventative antibiotics. Or for patients on certain treatments with a history of shingles, you might have like acyclovir, which is an antiviral, or valacyclovir to prevent shingles reactivation. So, for example, on that obinutuzumab medication. So it depends a little bit on the specific situation, but sometimes that can be utilized depending on the type of infection. Not always, though, unfortunately.
So we did have a question from a patient who wasn't able to be here today, but he pre-submitted this to ask you. He's been struggling with pneumonia for a while now. He was hospitalized in October, has been battling it since June. He's currently undergoing monthly immunoglobulin infusions. He's asking if he should be taking any other medications besides IVIG to assist in his recovery.
Yeah, I'm so sorry to hear about that infection, and hope that he is doing okay. I think this is not an uncommon scenario where patients have either a long course of one infection or multiple episodes kind of back to back of the same type of pneumonia. It's hard to comment on specifics here. I'll just say what my advice would be to make sure your oncologist, is partnering. It sounds like in this case, probably with an infectious disease doctor and or pulmonary specialist, making sure that they have really the data and workup that they need to tailor, whatever treatment for the pneumonia, whether that be antibiotics, if it's a bacterial infection, alongside the other care of the CLL.
Great. I'm not seeing anything else in the chat. I'll just give it a few more seconds if anybody would like to verbally mention anything. Okay. We do have a few more minutes. We'll wrap up right before the hour, if not sooner. But Dr. Thompson, you've mentioned several times about the importance of CLL research. I know you're involved in quite a bit of research. Would you mind sharing with us some of the promising things that you're working on or in the CLL landscape in general?
Yeah, sure. I think that there is so much hope for patients and doctors in CLL in 2024, and we have really, really good treatments right now. And that's all thanks to patients and their caregivers who've really had the courage to take part in clinical trials and clinical research. So drugs that are used to treat CLL, like ibrutinib, acalabrutinib, zanubrutinib, venetoclax, pirtobrutinib, all really in the past decade, although the trials started a couple years before that, have been approved by the FDA, for various stages of treatments for patients with CLL. So we have a lot of good tools in the toolbox. Now we're working really to refine those tools. So here at Sloan Kettering, I'm part of a team of CLL doctors, and we offer clinical trials for patients, from initial treatment and then even to phase 1, first in human clinical trials, where we're looking at new approaches to really for patients who've relapsed on all of the available standard of care therapies. So that's something to keep in mind. I think asking your doctor, or of course, we're happy if you're in the area or to see you here at Sloan Kettering, about clinical trials really at every stage of the disease. It's not just for patients, who, maybe it's often thought about, oh, I don't qualify yet. You might qualify for a clinical trial, and clinical trials can be testing not just new treatments, but refining for example, how long we give a treatment to a patient, or personalizing it to you based on something called MRD testing or minimal residual disease testing. So there's a lot of different options there. A lot of my focus is on, getting new therapies out for patients. And so there's a lot of exciting clinical trials, that have a lot of hope. Bispecific antibody trials here we have at Sloan Kettering. Trials, you've heard of BTK inhibitor. We now have trials looking at BTK degraders here that we're participating in at Sloan Kettering. And a couple of other novel pill-based therapies too. So there's a lot of work going on there. We also, I have patients who have graciously donated blood so we can do additional studies. I partner with laboratory colleagues here at Sloan Kettering, and we've done some work looking at why certain patients become resistant to certain treatments, looking at the genetics of the CLL, and then how that genetics is impacted while they're taking drugs. And we offer kind of a comprehensive at Sloan Kettering. We have, for example, our own genetic testing that we can do on for CLL patients, for example, the blood, and then we can look at that throughout the patient's disease course. So also working with laboratory collaborators, as well as the work we're doing in the clinic. So definitely a lot of exciting trials here and other places. And I would ask your doctor if that's something you're interested in, kind of no matter where you are in the stage of the disease.
Wow, we could do a whole hour just talking about what's new and what's being looked at and what's coming. And we're just so grateful for all the work you do for the CLL community and bringing new therapies to patients and working on all those important topics. So thank you for being here with us today. We learned so much. HealthTree is actually very invested in research as well. So I'm just going to end here by talking a little bit about a really important program that we offer called HealthTree Cure Hub. At HealthTree, we believe that educated patients and researchers create better and faster cures for patients. So HealthTree Cure Hub empowers patients with the knowledge they need to actively participate in their health journey while providing researchers with valuable insights from real-world experiences like yours. Connecting patients and researchers not only accelerates the development of innovative treatments, but it also lays the foundation for a future where more educated patients and research leads to more effective and personalized cures. So we invite you to join the 12,000 and counting blood cancer patients who are currently benefiting and impacting their outcomes while accelerating research by participating in HealthTree Cure Hub. There's many things that HealthTree Cure Hub offers. It's a one-stop platform that accelerates research by connecting you to surveys and studies that are submitted by CLL experts. You can securely connect your medical records to track your disease and have a comprehensive overview of your medical history. It allows you to discover clinical trials that are specifically personalized to you based on your medical data. You can find and connect with a genetic twin that has similar genetic features as you, and you can see what treatments they've tried in the past. And it allows you to gain access to a database of side effect solutions provided by other blood cancer patients as well. So you can enroll in HealthTree Cure Hub by visiting the link at the bottom of this slide. I'll send it out in our post-event email as well. Our patient navigators are also available to help you enroll in this platform. There's a chat feature on our website where you can get in touch with them too. I'd also like to mention our next adult CLL webinars. We are moving full steam ahead with CLL in 2024. We're going to have a whole host of events. We're very excited to offer CLL events now within our foundation. So our next ones will take place in February and March. On February 13, we'll be talking about finding financial support and resources for your CLL treatment with financial advisor Diana Valentine. On March 18th, we'll hear from psychotherapists about tips for CLL patients on managing anxiety and depression. You can sign up for these events by visiting our website, the link at the bottom of this slide here. And more. We will have more registration pages up soon for additional CLL events. We're always looking to hear about what's important to you as a CLL patient. So if there are specific types of webinars, specific topics you're interested in, please feel free to let us know via email what's important to you as well. I want to again take a moment to thank our HealthTree community for CLL sponsors, without whom this event would not be possible, who are AbbVie and Genentech. And I'd love to thank you all for being here today for our first CLL event, for helping us to build a strong HealthTree community for CLL. I hope to see each of you at our next event in February, and please do not hesitate to reach out to any of us about our upcoming events. So thank you, Dr. Thompson, and thank you everyone for being here today.
Yeah, thank you all.